Right. Hi, everyone. My name is Kayla Fulgenetti. I am the Senior Director at Elephants&Tea, also a very proud member of the AYA Power team. I am so happy to welcome you to the continuation of Season 3 of AYA Power, moving forward with purpose. Just as a very quick reminder, if this is your first session with us, we are so happy you found us and that you're here. Power is a training and education initiative providing oncology workforce with education and resources for the adolescent and young adult cancer community. And it's brought to you by Elephants&Tea and the AYA Oncology Education Working Group. I have just a few quick announcements and housekeeping, and then we will get off to the star of the show and what you all are here for. But each month, Power brings in an expert to really share information, share insights on topics that are relevant to the AYA community. And each of our sessions are recorded. I'm going to drop a link in the chat. If you have not checked out our website yet, not only is that where you can go to sign up to get information about future sessions, but it is also the home of all of our on-demand content. So all of Season 1 and all of Season 2 lives there where you can check out the videos and make sure that you are kind of looking at those to see what is available, what else we've been doing, and hearing from the incredible faculty that has been a part of the previous 2 seasons as well as Season 3. It will all live there. It is ready and waiting for you to check out. So there's an on-demand button at the top where you can scroll down on the website to find that. A huge thank you to our sponsors for supporting Power, our founding sponsor, I'm Not Done Yet Foundation, and our supporting sponsor, Azi Pharmaceuticals. We also want to call out that we are hoping that this is a very engaging and interactive session through the Q&A and the discussion that we always get to have with our incredible experts that join us here. There should be a Q&A button at the bottom of your Zoom call. If you have questions for our speaker, as you think of them, please make sure you drop those in there so that we can facilitate a really robust conversation at the end. We also just really want to recognize how hard it is, the work that you all do in this space. We love seeing you all here. We love seeing your faces and your engagement with the content and our speakers. And our hope is that, we really just acknowledge that we are a community here together, supporting each other and really trying to move forward the care for the AYA community. With that, I will pass it over to Mike Roth to introduce our speaker.
You so much, Kayla. I was thinking as you were talking about kind of Season 1 and Season 2 being available, whether it's going to be available on Netflix or Paramount or the new combined entity. But yeah, we're really appreciative of the folks who have been with us for the past 3 seasons now, and also our new folks who have been joining us. The goal is to get this important information out to as many providers and folks who support our patients as possible, because we know this is essential to improve health and quality of life. So on that note, it is an absolute privilege to introduce my friend, colleague, collaborator, Dr. Anao Zhang. I will say he wins the award for the most purple background that we've had for a speaker over the Power years, but a little bit more formally. So Dr. Zhang is now the Behar Endowed Associate Professor in Psychosocial Oncology, and he's the director of the Interdisciplinary Psychosocial Oncology and Palliative Care Research and Practice program at the University of Washington School of Social Work. His research focuses on psychosocial oncology, adolescent and young adult cancer survivorship, and integrated mental health interventions for individuals with comorbid conditions. As an applied quantitative methodologist, he employs advanced statistical approaches, including causal inference and machine learning. I don't think you often hear that methodology and the mathematics, as well as the psychosocial components in one person's background, which I think is really a big strength for Anao. And clinically, he's licensed as a social worker specializing in CBT and solution-focused brief therapy. And he also serves as associate editor of the European Journal of Cancer Care and Psychosocial Oncology, or Psycho-Oncology. I will say right before this introduction, he recently moved from University of Michigan to the University of Washington. And I was trying to think of whether there was any connection between Wolverines and Huskies. And when I used ChatGPT, the answer was none, only that Dr. Zhang has now worked at both institutions. So on that note, I will hand it over to you and now thrilled that you're with us presenting on an incredibly important topic.
Well, thank you, Mike, for such a kind introduction, and thanks, Kayla, for the invitation, and thank you, AY Power, for this opportunity to share with all of you some of my thoughts regarding psychosocial and palliative care for the adolescent and young adult cancer population. I think you all can see my screen.
Perfect.
Yes, it looks great. Awesome. All right, so good afternoon. It's really wonderful to join this session. So for today, I will be talking about the challenges and likely, and more importantly, the opportunities in providing psychosocial and palliative care to adolescents and young adults with cancer. As we all know, this is a population that sits at the profoundly unique intersectionality of their own developmental trajectory, their illness trajectory, and the healthcare system. My hope is that we would all collectively together walk away with not only a clearer understanding of what we do know where we are in terms of the field by and large, but also a sense of where we are as a community that we can move forward as the next step. As a brief disclosure, I do hold equity in Entertain Me Well, which is a company that develops one of the technology-assisted interventions that I may reference in this presentation. And then, as always, all the images and pictures used today are included with permission. And before we go deeper, I would like to call this naming the elephant in the room, which is the definition or the lack of a clear distinction between the key terms that are often used interchangeably, but likely going to cause very different interpretations in our larger field. So the article that you are seeing on the screen was published in the Lancet Global Health, right? If you read the article, it's the title of the article says Supportive Care in Cancer: New Directions to Achieve Universal Access to Psychosocial, Palliative, and End-of-Life Care, right? So thinking about all of these terms are being put in the same title. Are we talking about different concepts? Are we talking about same concepts? Are they overlapping? And an interesting thing also to look at the author's affiliation. I think it represents a good international representation of the authors are coming from, which I think it definitely speaks to the diversity and heterogeneity, if you may, when we are thinking about psychosocial, supportive, and palliative care, just by and large, but more so specifically for the adolescent and young adult cancer population. So just to frame this a little bit in the context of today's presentation, supportive care, how I view that, encompasses the holistic prevention and management of treatment-related side effects. So that's including physical, psychological, social, and spiritual. Psychosocial care focuses specifically on emotional, behavioral, social, and mental dimensions, whereas palliative care which often gets conflated with the end-of-life care, is actually a specialized approach that centers on improving quality of life through symptom management, decision support, and aligning care with patient values. And I think it goes without an argument that each of these domains is critical in cancer care, and specifically for AYAs, they are of amplified significance. And on a side note, that it is beyond the scope of this presentation for me to really settle which definition is the best for which term. So here I'm really just offering all of you a definition that I personally often use, and then I believe that has good literature support and backup. And in no way there is an intention to imply this is the only or correct way of defining these key terms. But I think just putting this up front really speaks to some of the challenges maybe at a later time that we're going to talk about as a field, some of the barriers that we're confronting at this time. So how I conceptualize the two keywords of today's presentation, which is psychosocial and palliative care, I like to think of both psychosocial and palliative care as the two essential pillars within the broader supportive care framework. So, psychosocial care again helps young people navigate the emotional and the social impact of cancer, questions about identity, autonomy, relationships, and mental health, whereas palliative care provides the specialized expertise in managing complex symptoms and serious illness communication. So, when integrated well, I believe that these approaches together would create a comprehensive support system, the larger supportive care, that is developmentally responsive and clinically meaningful for the AYs with cancer. So this figure, I hope that many, if not all of us, are very familiar with, comes directly from the 2006 AY Oncology Progress Review Group report, and which remains, I believe, one of the most influential national document guiding AY cancer care. So the language on the slides on the right side are taken verbatim from their recommendations. So I wanted to point out that even though in that report originally, not all of these bullet points are explicitly tied to the psychosocial and palliative care for AYAs, but I would argue that every recommendation here implicitly points to the domains where AYAs have heightened psychosocial and palliative care needs. So, for example, the call to identify the characteristics that distinguish the unique cancer burden in the AY cancer population really acknowledges that AYs face disruptions in identity development, independence, relationship, life planning, and many other domains, all of which carry deep psychosocial implications. So that is really to say that psychosocial and palliative care needs and the necessity for these interventions have been identified very early on and as a field, just by and large, probably before the 2006 report, but I think it was definitely being implied and indicated in that important document. So why are AYs different, right? And I think this is probably a well-known topic to many of you. So first, really, we're thinking about the unique developmental landscape of the AY cancer population. They are forming identities during this age range, and they're seeking autonomy. They are navigating the rapidly changing roles in schools, in work, and in family life. And in addition, AYAs often don't fit neatly into the pediatric or the adult oncology models, as many of us are very well known about this challenge, which does create fragmentations in their care experiences. And there's even more, I would argue, implications for their psychosocial needs, because thinking about it's not just treating the individual's medical disease, but also all the other aspects that surrounds an individual. And finally, although providers often sense that AYs struggle with distress, uncertainty, or decision making, and these needs are often not systematically identified, and even in settings when these needs are, they are not often comprehensively addressed. And then, of course, on top of that, what we are often confronted with are the underreporting of their psychosocial and palliative care needs just by AY themselves. Some of my AY patients and study participants that I interact with, that their reaction to me was always, it's no one else's business. I don't want to let people know, right? So that's sort of that mentality that comes in with their not necessarily full willingness to share about what they're going through psychosocial and palliative care wise. So the result is that we are then now serving a population with disproportionately high psychosocial burden and inconsistent access to supportive and palliative care services. So now what I want to do is really to turn to the literature, kind of share with you all what I believe we are at maybe a higher level in terms of the general landscape, in terms of the psychosocial care and palliative care research for the AY cancer population. So let's start with the psychosocial supportive psychosocial care intervention literature. So in the broader psychosocial space, we are seeing notable progress, especially over the past 10 years. A key scientific indicator is really the number of systematic reviews and or meta-analysis studies that were published that's focusing on psychosocial interventions supporting the AYA cancer population. The overall trend is very promising, and with an increasing number of randomized control trials that are more rigorously evaluating different interventions. So, what does the intervention landscape look like? So, if we look at the earlier reviews that are between, sorry, give me a minute. Yes. So if we are looking at the earlier reviews that are between 2015 to 2019, we identified only a small handful of studies and these are usually small pilots and with modest sample sizes and feasibility outcomes. More recent reviews, however, we're thinking about 2020 and later, we started to show promising growth in both the quantity and the quality of interventions. We're seeing stronger methodological rigor, better theoretical grounding of those interventions. And I wanted to highlight this piece. The reason being there's an burgeoning of literature, both quantitative and qualitative, started to inquire and to work collaboratively with AYA cancer patients and survivors regarding their preferences, their needs, right? And all of these knowledges that are generated are now translating into some of those theoretical grounded intervention components. That is really to say, we no longer just splash a CBT intervention and then attach that to say, if we deliver that to AYA, it's going to work. People are literally thinking about how can we modify even some of the change mechanism of the CBT intervention, just as an example, to better fit the needs and the preference of AYAs and AYAs with cancer. So we are seeing some interesting theoretical innovations there in that space, which I find it very encouraging. And of course, as a result of that, we're seeing more mature intervention designs as well. In terms of the strongest research evidence that are available, so much of the work to this date has really focused on improving patients' internalizing symptoms. So we're thinking about anxiety, depression, psychological distress, using developmentally tailored content and technology integration. We are seeing, however, a limited evidence when it comes to externalizing outcomes such as aggression, self-harming, and then the effective interventions among AYA cancer patients who likely also have other comorbid severe mental illness diagnoses such as schizophrenia, etc. So these are considered the domains of gaps in terms of what we know about this larger topic. Despite the progress that I've described and shared with you all, the level of evidence is still evolving. Many interventions remain in the pilot or small randomized trial phase, and only recently that we begin to see some larger scale trials or multi-site studies. Though encouragingly, we are seeing the field maturing in a quite impressive speed, meaning interventions are moving further along the development spectrum from conceptualization to refinement and to more robust evaluations. A notable gap, however, remains with most evidence focuses on the active treatment phase, while the post-treatment survivorship period remains understudied. And I wanted to clarify that I'm not saying that there is no study in that area. I'm just saying that relative to those patients who are undergoing active cancer therapeutic treatment, the research into the survivorship space remains relatively limited, at least when it comes to published studies. So this is sort of where we are in terms of the psychosocial intervention space. And now I wanted to switch a little bit to the palliative care space. And this is really in an area that we have strong conceptual consensus, but with relatively, and especially when you compare that to the psychosocial space, with relatively limited and empirical evidence, especially when it comes to the adolescent and young adult cancer population. A majority of the existing research evidence has been focused on recognizing the significance of palliative care and describing the challenges of the field. So really describing the problem, not necessarily how do we solve the problem. In addition, we also know palliative care improves process of care outcomes. So here we're thinking about we have good research evidence documenting palliative care reduce hospital utilization, and it improves hospice access, and it has better alignment of care with patients' preferences. Importantly, when it comes to psychosocial functioning or patient-reported outcomes in the larger context of AYA palliative care, data, empirical data and research in that field is relatively more limited. There are good consensus from the literature in terms of the delivery challenges that we're observing in terms of thinking providing palliative care to AYs with cancer. We're often looking at late or absent referrals to palliative care. We're looking at high intensity of end of life care, meaning many of the patients still received quite intensive and aggressive not curative intent, but aggressive chemotherapies or radiations during the last 1 to 4 weeks of their lives. And there is clearly a lack of developmentally appropriate communication and decision-making support as well that we're seeing that's missing in the literature. Now, despite these gaps that I've mentioned, several promising interventions are really emerging. One notable one is the FACE-TC, a family-centered advanced care planning intervention, which has shown strong potential in facilitating meaningful and value-aligned conversations. There's also Voicing My Choices, which is an intervention that provides developmentally appropriate tools that empowers AYAs to articulate their preferences and needs at the end of life. And there are also programs like PRISM and meaning-centered approaches, which further broaden the toolkit for resilience, coping, and meaning-making. And these tools really illustrate that AYA-specific palliative care interventions is not only possible, it's impactful when being done and delivered right. Though again, while many of these interventions are well backed by research evidence, most are still in what I would refer to as the evidence accumulating stage, meaning a larger clinical trials supporting their clinical effectiveness, the real world effectiveness is necessary, and then probably more so the need in the hopefully in the near future to move on to implementation focused studies. So this is one of the three questions that Kayla gave I think most of the speakers as we were thinking about developing the slides, which is where do I see the field of AY oncology going into the next 3 to 5 years? So I'm of course here specifically thinking about psychosocial and palliative care interventions. So if we zoom out and thinking about this question, the trajectory for me is relatively clear. We will continue to see growth in the number of promising interventions that are going to be developed and evaluated, and the evidence base will continue to accumulate. So I believe that is the sort of the realistic movement that's going to happen in the next 3 to 5 years. But I would argue that to truly move the field forward, what we also need simultaneously are really large scale and implementation focused trials that's going to test how the interventions are going to work in real world clinical settings. And this, I believe, the next frontier is not just innovating in the intervention space, but really its translational pathway to real world utility that we need to overcome collectively as a field. And now I want to translate to a little bit why we aren't already doing things like this. And one of the greatest privilege of me doing my job, being a researcher, caring, sometimes having the flexibility wearing the hat of a clinician, is the joy of conversing and having conversations with patients, with clinicians, with colleagues, with researchers. So I want to just share 3 quotes that I think are indicative of some of the challenges that we're collectively facing as a field. So one of my colleagues actually said to me, there are so many interventions out there with comparable level of evidence. Which one should I use, right? So that's always a struggle. And another of my research colleague and collaborator said, I have thought this intervention is an evidence-based approach for AYs with cancer, but when you look at the literature, I'm not quite sure anymore, right? So it really speaks to we may think that there are evidence-based interventions, but if you really take a closer zoom in into the literature, the level of evidence may be there, but not quite to the extent that we would want it to be. And finally, this is from one of my colleagues at Michigan who said, I really like this intervention or think this intervention will benefit my patients. How can I get that intervention into my clinic, right? So we're also seeing that translational barriers. So really, what do these things are telling me? So for me, if we're thinking about this, the field I think is still struggling with the segmentation, meaning intervention development and an evaluation often occurred in silos without clear pathways towards scale up or sustainability. Even for interventions that are have progressed far along the developmental spectrum, face barriers when we are transitioning from grant funded research initiatives to clinical implementations, right? I think many of you thinking about your own cancer centers, the institutional barriers that's likely going to be there when you know that there is an external evidence-based intervention, maybe in a technologically assisted intervention, and what are some of the challenges that's going to really be in the way for us to fully implement that external, that foreign, if you may, intervention into your own institution, even just simply from an IT standpoint, on top of there's financial concerns, there's patient privacy concerns, all of these aspects and domains. Um, Engagement remains a major challenge. AYA participation in research studies versus in the real world uptake of an intervention. Sometimes they would mimic the study performance, but other times we are seeing that the real world uptake of a particular intervention got not as ideal as what we've learned from the study. If you think about in a protected study environment where participants are getting probably more surrounded support from the study team, from the research assistant, and with potential financial incentives versus in the real world that you're really getting this, taking time out of their day to receive certain type of psychosocial and palliative care intervention, it would require another level of engagement. And we continue to see, of course, and to grapple with the fundamental heterogeneity of the AYA cancer population, thinking about the 15 to 39 age range, pediatric versus the adult cancer diagnoses, early versus late stage, curative versus palliative trajectory. Are we designing an intervention for everyone? And to what extent we want to tailor to the individual, to what extent it becomes not feasible, not resource meaningful or effective for us to tailor this to the T's versus we just wanted a too broad intervention that it only fits a small subgroup of the population in reality, right? So these are all the challenges that I believe that we're grappling as a larger field. So, what are some of the opportunities and future effort that I think we can take collectively just as a field? So, one of the most exciting opportunity is the potential to build national infrastructure for psychosocial and palliative care trials. And we've seen what is possible. I wanted to say that through the groups like COG and other national cooperatives networks. Though also I wanted to acknowledge that these groups are most effectively designed and primarily designed for cancer therapeutic trials, and supportive trials are often included and may not always be the primary focus. And I would hope if I get the magical wand to determine how the world is going to operate, I would hope that we would expand or replicate some of those models for psychosocial and palliative care models would transform the field. Those larger cooperatives that are designed for psychosocial and palliative care trials in collaboration with some of the existing collaboratives, or maybe complementing to some of the existing larger collaboratives. I also want to highlight the possibility of grassroots investigator-initiated consortia. And this is an approach that I believe could accelerate multi-site testing and harmonize measures and create shared learning systems. One thing that I always brag to my other colleagues, both on the social work side and on the oncology side, is that in the field of AYA, we just have the best people. And with the right people, with the best team, you make things happen, right? So thinking about utilizing and harnessing those momentums and finding your institutional champions in facilitating some of those more challenging works, more demanding clinical trials, I think is absolutely critical for us to move forward as a field. And uh, this is another reason that I'm very excited to share this work in this platform because I believe that infrastructures cannot just be built by researchers alone. We see a huge role of NGOs and NPOs and community-based partners to play a critical role in response to the sort of the second question from AYA Powers, which is what is one of the things that we can do together as a community to make real progress for AYAs now? So rather than supporting, and I'm really speaking and talking to all our community partners, right? So rather than supporting isolated project-based efforts, so which are highly appreciated and grateful, myself included as a researcher, when I reach out to community partners and organizations, they are always so happy and so willing to participate. But to a to a time point, and I hope that collectively as a field that we will be able to move beyond those individual project-based efforts and to look for opportunities for coordinated investment in the systems that would enable trials that are much larger to support, for example, data platforms and recruitment pipelines and patient navigation, workforce training. And I think this is really a moment for collective action. And we also have substantial room to strengthen engagement, right? Thinking about AYAs are really discerning consumers of information. They respond to what I would argue emotionally resonant content, dynamic formats, and shorter delivery structures, and even elements like cliffhangers that mirrors the media that they interact on a daily basis. And then as a field, I think we need to translate what we know about AYA preferences into actionable design principles for these interventions. Engagement, I think, and then I think all of you would agree with me, is not a nice to have, it's a prerequisite for intervention success. And of course, there's the tricky balance of to what extent that we're engaging AYA versus to what extent that we are making them dependent on those platforms and interventions. So there's also a tricky balance for us to manage in that area. Of course, as we've talked about social media, there is the clear topic of artificial intelligence and machine learning. I do want to start by saying that they offer very exciting, though carefully bounded possibilities. There is a couple of efforts and research initiatives that I see are already happening in this larger psychosocial and palliative care field. We're seeing researchers looking at population level data set, and we are using predictive models to identify psychosocial and survivorship risks, and therefore integrating some of those predictive modeling scores into make informed decisions in supporting preventive efforts and tailored intervention content and individual needs. Algorithmic tailoring could help us balance the tension between earlier what I've referred to as the scalable intervention, the one size fit all versus personalized care. But of course, ethical considerations that's including equity, transparency, avoidance of harm must guide all of this work. So here I want to offer just a couple of uh, research ideas that I've heard people talking about. I know that some of those ideas are already being funded. Other of those ideas are application undergoing. So I won't go into too much of the detail and the specifics, but I just wanted to maybe give you a broader, higher level appreciation of some of the interventions that are being considered, right? So thinking about wearable technologies, which would allow uh, potential pathways to understanding the movement of the patient, the geographic location of the patient alongside other biomarkers that we will be able to detect, right? But thinking about if we're to do smoke cessation for cancer patients who during the post-survivorship space, right? They need to get their cigarette probably from a store. These are geographically available locations. So to a certain degree, in a bounded way of tracking their movement, to getting closer to a cigarette store, getting further away from cigarette store can create a lot of interesting and innovative design perspectives in creating some of the psychosocial and palliative care interventions when we're thinking about. There's also potentially more nuanced technologies that would allow us to innovate some of the research paradigm, right? Thinking about now the technology is absolutely there for us to track the eye movement of the participants. Thinking about adolescents and young adults sitting in front of a computer, completing a decision-making tool, completing a psychoeducational content, right? Where their eyes are looking at, what are the information, what are the elements of the design of the intervention are really getting their attention. These all becomes traceable and to a certain degree measurable design elements that would allow us to really kind of potentially untangle some of the myths that we typically treat as a black box when we're thinking about psychosocial and palliative care intervention. But with these more recent technological advancement, they really become something that is possible and realistic. And with that said, of course, integrating AI into supportive and palliative care would require a lot of caution and oversight. AI should not, in my view, replace clinicians. It should extend their reach, not undermine their relationship with the patient. We must remain vigilant about issues like digital addiction, biased algorithm, right? The algorithm only produces what you feed the data to it, and an unequal access. Our responsibility as a field is to ensure that technological innovation enhances rather than destabilizes the quality and humanity of care. So, where do we go from here? I think we should think boldly about cross-boundary and transdisciplinary partnership. That's between research centers, cancer program, advocacy organizations, tech innovators, and governmental bodies. We can lead the development of AI enhanced screening, risk profiling, and stepped care models. We can also design interventions that are modular, flexible, and individually tailored. The question is whether or not the innovation is coming. It is whether or not we as a field, and I would argue we as a field in terms of psychosocial oncology and AY care, are we ready to guide it, to oversee some of the most recent conversations that are happening in the technological field? And finally, we already have strong foundations to build on. I think this, I may not be the first person to highlight these initiatives. There's the Childhood Cancer Data Initiatives, as well as the SEERS program. And there are other national efforts that are offering infrastructure for data, surveillance, and long-term monitoring. And these initiatives show that when we invest strategically, we can create conditions for transformative research and to better serve the AY cancer patients and survivors for their supportive and palliative care needs. With that, I want to thank you for your time listening, and I'm happy to take questions.
Thank you so much, Anao. That was a really great talk. It provided a lot of things to think about in terms of, what's available, what's not available, and where do we go. I will say my favorite slide, I think, was your second or third to last slide, which kind of puts it all together. And thinks about how do we screen, how do we, knowing the limited resources that are available, leverage potentially a stepped care model to provide, maybe more general services to the broader population, and then those where that is not effective or there's a higher level need, provide more tailored personal approaches. I think that's where a lot of this work needs to go, but we're still in infancy in terms of actually doing this for psychosocial care as well as a lot of other needs. I have a lot of questions, but that is not fair because we talk a lot, so I can ask my questions any day. So let's get to a little bit of the Q&A. Scott and I also want to open it up for folks. If you want to raise your hand as well and come off mute, you are definitely welcome to. But let's start with Emily's question. What psychosocial interventions specific to AYAs with cancer are available besides Voicing My Choices and PRISM, which you nicely shared in your presentation?
Yeah, so the short answer, I would say, if we're to think in the domain of evidence-based intervention, there's really not a lot. And I think that really speaks to the challenge, right? So one of the intervention, Mike, you know this because I'm working with Mike with our uh, intervention, which is called Mind Your Total Health. It was funded by the National Cancer Institute. It's still in that development stage, and then I know of there are maybe close to a dozen of similar interventions that are still in the developmental space, which really, I think the question itself is so pertinent because I think it really reflects where we are as a field. And then I would even say, in terms of for Voice My Choices and for Prisms, they are more on the palliative care because these are more in the decision making domain. So for me, these are more in the palliative care domain. So when you're strategically thinking about psychosocial interventions, we don't really have that many options that's out there. That is not to say that, psychologists who are well trained and clinical social workers who are well trained to provide interventions to these populations, they don't provide evidence-based interventions. On the contrary, I think they do. But I'm just saying, if we were to thinking about an existing manualized intervention that we are thinking about more generalizable to the larger setting, I personally don't see there is a lot of options that are available to us.
Yeah, that's really helpful now. And I think it's a good time to transition to a question by Dr. Choi, who I know is one of those colleagues who's also developing psychosocial interventions focused on
Yes.
expressive writing. So Dr. Choi asked specifically about palliative care, and knowing that palliative care is often underutilized in AYA oncology for a host of factors, what is contributing potentially to this limited care delivery of what is really essential care and is standard of care? And have you explored whether early integration of palliative care improves outcomes in AYAs, knowing the literature in adult and older adult oncology?
Yes, that's such an excellent question. So I'm going to speak largely based on a recent systematic review that our team did and was published in Psycho-Oncology. What we did find, by and large, in the field is that there is a couple of contributing factors to this. The first, one of the, I would describe it as interesting, but interesting isn't the right word, is that patients and families still have that misperception of palliative care means end of life care. So when you are introducing the concept of palliative care to patients and their families, sometimes they just get spooked, they get extremely worried, and it would come back with the question why we're talking about palliative care here. And physicians often need to explain to the patients and in the families, oh, palliative care actually doesn't mean it's end of life care. All of these back and forth conversation, I think, really contributes to the dynamic. Again, this is me educated guess, the dynamic of, I think, causing palliative care physicians and oncologists are less likely or are less willing. Of course, there is a lot of individualized factor, but physicians are less willing to bring this topic up early on, especially when curative care isn't an option. And then I think when I'm thinking about palliative care in AYA, I would call it a field of double divide, meaning, right, if you think about AYA, we're thinking about pediatric oncology and then medical oncology. But if you think about palliative care, there's a pediatric palliative care versus the adult palliative care. And what we are seeing is that there's relatively an abundance of resource of palliative care physicians in children's hospitals versus in the adult hospital because of the high volume of patients and the high needs. So their palliative care physicians are super stretched thin. And I think that issue then, if you put AYA into the picture, then AYA are being caught in not only the pediatric medical oncology divide, but they're also being caught in the middle of pediatric and an adult palliative care divide because they don't necessarily get all the abundance of resources coming from the pediatric world. So workforce is another concerns, but I think it eventually translates to the patient world. And then that's causing what I think the palliative care hasn't really been introduced early and soon enough into this patient population.
Yeah, those are really insightful comments. I'll add one additional thing that I've learned from my adult colleagues who are super busy, and the majority
Yeah.
of their population are older adults, and they're quite comfortable with helping patients who have incurable cancers or cancers that are very difficult to treat. But when it comes to seeing a 25-year-old in their clinic, it's very different than someone who is 75 or 80
Yeah,
years old, and sometimes they've expressed discomfort with broaching that subject.
absolutely.
Scott, I'll pass it over to you for some additional comments and questions.
Yeah, thank you. So one of the next one was when you're talking about the wearable technology. So if you can speak more to that in terms of the costs for that, the logistics of it, for the hardware, the software, how long then they get that.
Yeah, so I would that's a great question. So I would maybe say it depends on two different scenarios. The first scenario is if it's in a strictly research context with external funding and likely philanthropic support from tech companies. I think some of those costs becomes relatively more reasonable and affordable. And I've known colleagues have worked with larger corporates like Google, like Meta. They would even donate those technologies to study teams, so they do become more affordable. But I think the devil here is that once the technology is found to be really good, and now we want, let's say, if all the hospitals start to purchasing these technologies and then actually using it for their patients, I would be the one to say I don't believe a lot of those larger companies and corporates would be say that we're going to give you a more affordable price. And so I can see the cost is going to be a little bit prohibitive in terms of when it comes to real world translation. And I can see that being a challenge. But in a research context, I don't think it's too much of a challenge, at least with my own experience and my experience learning from my colleagues.
Thank you. And then a follow-up question came in. Has there been any participatory design work in terms of how the patients themselves prefer to wear it or use it in terms of their psychosocial health?
Yes, to my knowledge, there are actually a lot of participatory work, and I think by and large, I would definitely want to give credit to the National Cancer Institute for several of their funding mechanism that they are requiring patient participation and stakeholder participation to be an required elements of the application of the grant. So I think that at the national level is now, at least with the AYE field, is a given expectation. So there's a lot of those. How do you, how should we design the wristband of the watch? How do you want the interface of the watch will look like? If it's not a watch, what are some of the other technologies? So we are seeing a lot of those conversations that are happening. But I think that all of you probably know what the answers are. The answers are it depends on the individual. So I think in my experience working with AY is that always give them options and then people will pick what they prefer the most and people like options.
Yeah, that's really helpful. And now For the first time, Scott and I actually got a personal text with a question, which was not in the instructions in terms of putting it in the
Yes.
chat or the Q&A, but we will still honor that question and ask it. The question is about resources that exist. So we know that there's a fair number of AYA nonprofits and effective resources that build community and provide really wonderful psychosocial support, address isolation. We're partnering with Christabel Chung, looking specifically at patients, caregivers getting access to these resources. What, what are your thoughts about how we get more patients access to resources that are currently available? So those resources are only as effective as their accessibility and uptake. Any comments on that?
Yes. So first, I do want to just to echo, Mike, what you said, right? So there are a lot of AYE specific community organizations and champions and partners supporting this population. I recently just stepped down from the board of directors of the cancer support community at Greater Ann Arbor. And one interesting conversation that we had at the board, which made me had my brain start spinning, is even though the cancer support community isn't AYA specific, CSC, cancer support community, are struggling to find AYAs and they are so eager to provide support to the population. So I guess my only comment to add on is that yes, we have a lot of AYA specific organizations and community partners, but also to think beyond some of the more general cancer support organizations and who are likely equally motivated and willing to provide the support, and they may also have a needs because they see AYA as an underserved population in their larger service profile. So making that connection, and I think would add additional layers of support to the population.
That's really helpful. I wouldn't mind opening that question up to the broader group here, knowing that folks have different
Yeah.
roles in serving AYAs. I personally think that is the biggest challenge of our time currently in AYA health outcomes, whether it's psychosocial care, psychosocial support, palliative care, providing cancer-directed treatment. I think we have a real challenge in boots on the ground care delivery and reaching the patients and connecting them with appropriate care and services. And I'd love for a couple folks just to come off mute or put in the chat if you feel comfortable of what are your thoughts in your local environments, how to make sure across your sites, whether it's a community site or a larger academic site, how we get all patients access at minimum to resources that are already available. Would love to hear some thoughts.
Yeah. And as we're waiting for people, I just wanted to make a quick point to your point, Mike, where you talked about sort of boots on the ground. How do we really reach the population? I wanted to share a quick. It's not an anecdote. It literally happened to us within the past 2 months. We were running a clinical trial at Michigan Medicine. It's a psychosocial trial. We started using the study flyers called the study flyer used the word, do you want to talk about your depression and anxiety, right? So we used the specific words IRB required. And then we had very poor engagement from the patients. And then thanks to our AYA program manager, Kate Donahue, I saw Kate here. She may have left, but Kate, oh, there you are. So Kate recommended, well, instead of maybe just saying depression and anxiety, why don't we actually thinking about some of the words that AY really cares about. For example, independence, autonomy, self-reliance, all of these keywords, which are related to depression and anxiety. And once we change some of these words, within the same day or 2 days, we have like 5 participants enrolled in the study because that's what they care. So I think to that point about getting that service to them, it's also about how we are framing these services so that it's actually appealing and engaging to them. And again, I think this is going back to my earlier point. I think this is where me as a researcher, it's so critical for me to collaborate with someone like Kate, who's on the ground, who knows the preferences and the needs of AYs with cancer. So shout out to Kate.
I was just gonna say, and a lot of those suggestions that we got for that flyer and the adjustments also came from our patient advisory council. So having that patient voice involved as well was a huge piece of
Yes.
that. So we're grateful for them. It's a great council.
Yes. Thanks, Kate.
Samantha.
I just wanted to say because I am an AY, so I'm a pediatric chemo provider, but I'm also an AYA survivor. And I got my care at Dana-Farber, and they have a really, really incredible young adult program. And I think that's it's something that isn't provided to us a lot, in my experience too, and even in my own clinic. Like there's so many other things to be considered that I think like the support services for AYAs isn't as clearly laid out. And I think that Dana-Farber does a really good job that like they have a young adult program such that they get notified when there are new people and they actually set up a consult with the young adult program. So I mean, I know that's like a lot to take on and that Dana-Farber's program is pretty well established, but I think it's really hard as a patient to seek out more resources when so much is thrown at you. So it's really cool at Dana-Farber that they do like provide the resources, but they also do like an intake with them and they show them the space and things like that. Because I do agree, a lot of people that I see come into different spaces, and I'm involved in a lot of the AYA online community. People will find one and they don't know that there's more others. So, also encouraging different programs to like hype up other programs and like share that. And then, yeah, I think having the patient voices in because some things just like don't hit us well, and it's not engaging, and some things do. So that's just kind
Yeah,
of my 2 cents.
absolutely. Thank you.
We are at the end of time. I know there's 2 questions pending, and we'll try to answer them via email. I'm happy to connect you guys to Dr. Zhang directly. We're going to kick it back over to Kayla. I personally want to thank Dr. Zhang for a wonderful presentation. I don't know if you want to bash your former Michigan Blue colleagues on the way out to become a Husky. I encourage it, but really just appreciate it now, not just what you presented today, but all of your efforts
Look at Brad.
to unite our community despite the differences that we have and who we root for. So thanks, Anao. This is a really enlightening
Thank you.
talk, and I really love how you highlighted where we need to go, not just the challenges, but what are the opportunities together as a group to move forward and do better for patients. So thank you, and I'll pass it over to you.
Yes, thank you, Now. Thank you so much. Thank you, everyone, for being here and participating in this session of Power. As always, I am going to drop into the chat our survey. We look at all of your feedback as we continue to adjust and think about future seasons and sessions. And speaking of that, I'm also going to drop in the link for our next session, which is going to be on Thursday, January 29th at 12 p.m. Eastern. Missing in Survivorship, Provider Insights on AYA Recruitment Barriers with Dr. Christabel Chung, who we just actually talked about. And so we wish you all very happy holidays in whatever ways you might be celebrating the end of the year and this season. And we look forward to seeing you all again in 2026. Thank you to Mike and Scott for always leading such a wonderful discussion with our experts. And now just a huge thank you again to you.
Thanks, everyone.
Bye,
Bye.
everyone.